the third and final one in the Asian regional series. And we've already had two very good, very powerful, very interesting workshops. One on and from Korea, and one from Pakistan and India on community health workers. And this one is focused on the issues of public and private healthcare and the problematic effects of promotion of private healthcare on public healthcare systems. Welcome especially to Anna Mariott, who has agreed to be co-facilitator, co-host, co-organizer of this meeting. So in a couple of minutes, I'm going to hand over to Anna, and we're going to bat the facilitation role backwards and forwards between us during the course of the meeting. Thanks also to all the speakers who've turned up and will be making contributions shortly. Okay, now I'm supposed to mute everybody to start with. But those of you who are co-hosts, all of you who are speakers, and all of you who are interpreters can unmute yourselves, which you might like to practice now. Yeah, excellent, very good. Okay, so nobody's dependent on me to unmute themselves. Okay, we're going to start, let's say the first thing I'm going to do is hand over to Anna Mariott, but the way the workshop will work will be like the others. One of us will introduce the subject of the workshop. In fact, Anna will do that. And then we're going to introduce each speaker in turn. And we're going to be asking you to observe quite strict discipline, because I think there's a total of 6 speakers, which implies 10 minutes each. So if you can use 10 minutes as a target, that will be terrific. We'll be very grateful for that. In practice, that usually means 12 minutes. After all speakers have spoken, they will then invite questions and comments from everybody, and participants can use the button below to raise their hands, asking to speak. But you can join in through the chat at any time during the course of the workshop. And then after a discussion about 30 minutes, the whole workshop will last for about an hour and a half, hour and 40 minutes. We'll close the workshop because we then move on to the next workshop, which is taking place in Chile. So a good move. Okay, Anna, can I perhaps hand over to you at this point for you to pick up on what we wrote as a simplistic summary of the subject matter, and perhaps introduce the theme of the conference, and you can decide whether to sequence that into your own contribution, or to invite Susan, who's next on the program. That decision is up to you, but I hand over to you now, and at some point you'll hand back to me, but it'll be in safe hands with you for the next hour or so.
Thank you very much, David, and thank you to everyone for joining as well, and particularly may I echo David's thanks to the panelists. I'm incredibly excited about hearing the contributions from a range of experts on the topic that we're discussing today, and just to highlight what that is, you know, we have a global consensus that countries must develop public universal healthcare systems. Sorry, this is a very powerful evidence-based narrative that countries must develop public universal healthcare systems. But we know that that is heavily resisted by commercial interests wanting to expand the market for private healthcare, which we know is not only potentially very lucrative in India, it is incredibly lucrative in India. And, you know, beyond local actors and both at the local community up to state level actors who are perpetuating this commercialization agenda, we know that that agenda is also being pushed by international institutions who have been helping the corporatization, financialization of healthcare in India. So we have a range of speakers today who will be speaking to these topics in different ways, using different evidence to explain both the interaction between state and the private and commercial sector, and the impact of these different actors on the commercialization and financialization of healthcare, and ultimately what that impact is on real people. And with that in mind, I'm going to start by just sharing with you some of the research that Oxfam has been involved in that is related to this. What I want to do is give you a flavour of a research project that we've been involved in over the last 4 to 5 years that focuses on the role that European development finance institutes have been playing in healthcare in all low and middle income countries, but that our research then provided a bit of a spotlight on what this looks like on the ground in India. And I know that my intervention will potentially overlap, I hope complement the presentation from Susan particularly, but also from all of the other panelists. So I'll start by introducing my research, and then I will pass over to you, Susan, to hear from you, if that's okay. So let me first start then by trying to share my screen. And please let me know if this is working. Can you see that?
Yep.
Great, thank you. Okay, so first, I just wanted to provide a little bit of context. So I work for Oxfam. I'm the health policy manager for Oxfam. Oxfam has been working in India since 1951, and since 2008 has been an independent affiliate and an Indian NGO. And our work on health in India has focused on 2 main pillars. Firstly, working to strengthen and make more equitable the public healthcare system, especially at the community and primary healthcare level. And secondly, efforts to curtail, hold accountable, and call for greater regulation of the private sector. And all of this in partnership with others. And through those years, we've consistently called out the disgracefully low levels of public health expenditure in India. We've celebrated the enormous impact even small increases of spending and political capital invested in the public healthcare system can have in the country, and have been witness to and campaigned against the proliferation of private healthcare actors across the country, which is, as we all know, has happened on an industrial scale. Not only emerging in the gaps left by government, but being actively sponsored and subsidized via government policy and spending. But as I said, we're also acutely aware of the external drivers of privatization and commercialization of healthcare in low and middle income countries, and in particular are extremely concerned about the role so-called development finance institutions are playing in this process. In the past, we've looked a lot at the instrumental role that the IFC, the private sector arm of the World Bank, has played in the financialization of healthcare. And we're currently updating our analysis of that in India, which is why I'm also really looking forward to Susan's presentation today. But in the last 4 years, we turned our attention to look at the role that European development finance institutes were also playing in this process. And in particular, looking at the UK's CDC, which is now called BII, France's Proparco, Germany's DEG, and finally the European Investment Bank. And our mapping of their health investments, as I said, was for all low and middle income countries over a 10-year period. I'm just trying to get my next slide up. Is that working?
Yeah.
Great. So just to give us a flavour of those kind of global findings from our research, we found a relatively small but very significant volume of donor finance going to private healthcare providers through their development finance institutes. We saw very significant use of financial intermediaries, a mix of financing instruments and methods, including loans or equity investments. And we saw that over 90% of the funds support large businesses, often transnational corporate healthcare providers and other healthcare businesses, rather than the small and medium enterprises they claim to be supporting. We've seen huge volumes of funds channeled via large public-private partnership hospital complexes, as well as large volumes through equity investments in corporate hospital chains, either directly, but actually mostly through these financial intermediaries, often located in tax havens. The majority of the funding that we identified was going to upper middle income countries. Now, our big focus in Oxfam is about pro-poor access to healthcare, universal equitable access to healthcare. And our analysis found that the vast majority of the for-profit healthcare providers funded by these European development agencies were going to expensive hospital chains. Nearly 90% of those that we could find information for were charging fees that were largely unaffordable for ordinary people, let alone people living in poverty. A concentration in urban areas, as I said, significant links to tax haven, and you know, trying to unearth much of this information was highly complex. Lots of very tangled webs of financial links between different actors, and actually accessing any data at all was a very time-consuming and difficult process. One of the inescapable conclusions of our work is that the European Development Finance Institutes pay minimal or no attention to whether or not their development spending to for-profit private health sector actors can or does improve healthcare access and outcomes for people living in poverty, including women and girls. And we wanted to follow up our mapping of investments at this global level with a closer look at exactly the kinds of healthcare providers being funded and their impact, especially people living in poverty. And India was an obvious choice due to the high concentration of investments in India and the longer history of financialization here. My next slide is basically a list, or a visual list of all the corporate healthcare providers that we identified through this research funded by the European DFIs. The only one not to invest that we could find from the data was the European Development Finance Institute. The UK, in contrast, was the most prolific investor, with both multiple indirect investments as well as about 5 or 6 direct investments in these hospital chains. Now, this was the status as of 2020. We know that this is a constantly moving picture because of mergers and acquisitions, but that's the list we identified at that point. And from this list, we chose 2 hospitals, Narayana and Care, to conduct more in-depth qualitative research, interviewing patients and local community members who were purposefully selected based on their experience of rights abuses at the hands of these hospitals. And we focused this research in 2 states, Chhattisgarh and Orissa. And what we found and heard will not surprise those on the panel, who I know have done similar work. And in fact, some on the panel helped us do this work. But what we found is evidence that has to be shared, and shared again with those who are making these investments decisions, sitting thousands of miles away from India, with little clue or perhaps no interest in the consequences of their decisions, and all in the name of development. In summary, we found evidence of severe mistreatment, grotesque and life-changing overcharging, leading to financial ruin for the patients and their families, misdiagnosis, unnecessary life-threatening surgery, and multiple cases of refusal of treatment. We heard many accusations of patients being kept alive on ventilators simply to further inflate healthcare bills. We identified an entire community displaced by the building of a new care hospital in Orissa, who are still 5 or 6 years later waiting for permanent housing. My next slide is just a selection, and it's too prolific to be able to read during a presentation, but I will leave up there. It's a selection of quotes from some of those patients and community members that we interviewed. Some of them incredibly powerful. And we'll be publishing our research this year. It was interrupted by the pandemic and unfortunately stalled the progress of the publishing, but we will be doing that. And so we will have a more comprehensive account of those testimonies from the patients and community members that we interviewed. The quotes give a flavour of the scale of fear felt by people using these facilities, the power inequalities, the abuse and the anger felt by people whose lives have been devastated by the behaviour and actions of these corporations. And in addition to the personal testimony, we also came to understand that the financialisation of these corporate hospitals, in large part driven by these international development actors, brought a notable change in the way these providers behave. Many commentators telling us that there was a shift in behaviour when these investments started. Yes, these were already profit maximising institutions, but somehow became more ruthless, more exploitative and more abusive since the equity investors via financial intermediaries came to town. And so not only do these donors bankrolling these facilities and corporate hospitals not pay attention to whether they are reaching people on low incomes, they really do pay no attention to the accountabilities of these companies to patients, and clearly do not engage at all on issues around the regulatory context in which these actors operate. So just to conclude my intervention, just to say that this is an area that Oxfam plans to continue doing influencing work and campaigning on. We believe, that the most compelling and responsible approach in this influencing work is to ensure that the voices and experiences of those most directly impacted by the behaviour of these publicly backed private healthcare providers are heard by policymakers and officials. And we need to do more collectively, we believe, to take this evidence of abuse perpetrated by these actors to those investors, to those officials, to those policymakers sitting thousands of miles away, in addition to the incredibly important work to hold the local government and national government to account in India. So I'll leave my intervention there. I've probably gone over my time, David, have I? I'm ever so sorry. I will stop sharing my screen somehow. And without further ado, please may I introduce Susan. And Susan, please, for speed and efficiency, maybe if you introduce yourself. And I'm personally very, very excited to hear your intervention today. So Susan, over to you.
Thanks, Anna. Yeah, I think my paper follows on nicely. In fact, and let me also share my screen. There we go. Oh, I should be quicker at this by now. So let me start by thanking PSI for their support. This paper that I'm presenting, and I can get my screen to cooperate. It's always a little bit of a challenge when it's hiding the full screen element. Sorry, I'm not having much luck today. Hold on, give me 1 second. I'm just going to share my other screen. New share. Oh dear, so sorry.
Don't worry, we all.
Just put it on my other screen. It's much better view. Okay, let's share that one. On full screen for you. So this research is from PSI. It was originally funded by Public Services International, and so thank you for their support. But I've continued to look at this topic, so some of it I've gone a little bit beyond what's in that original research. I'm also sharing the wrong screen now. You can see my notes screen, can't you? Can you see my notes screen or just the full picture?
Well,
yeah,
I can,
happened.
yes. I don't know whether.
Yeah, I think that happened with display settings. Ah, there you go.
Oh, there you go.
There you go.
That's it.
So
yeah.
I'm going to start a little bit back from where Anna started, which is to talk about the emergence of neoliberalism in healthcare financing. And you probably know mostly where that starts. But I'm going to talk about it in 2 phases, and the financialization one being where we're at now, but the earlier phase of the first phase of the Washington Consensus or structural adjustment started with corporatization through cost benefit analysis and healthcare segmentation, and the introduction of private providers or private segments into the public system through cleaning, food, pathology, or just wholesale introduction of private providers. The second phase, or from the rolling in the private in the state in the first phase of neoliberalism. The second phase is very much about rolling out the market, as Matthew Spark and others have pointed out. It's not just rolling back the state, but rolling in the market through the kind of financialization mechanisms that Anna talked about. But this brought us also into the agenda of the Sustainable Development Goals and universal health care. But the important thing about universal health care in this agenda is it's always to be done through health insurance, which leaves open the doors for private providers, allows provision of very minimal packages for the poor, and comprehensive services for those who can pay. It's still about transferring responsibility for healthcare financing from states to households. And the privatisation processes haven't been fast enough. I'm really interested in, a lot of my research is on the multilateral development banks, the World Bank and others. So they use things like public-private partnerships, PPPs in particular, as a way to, more rapidly bring in those private providers. So to set up the context for Indian healthcare pre-COVID, most of you probably know, but the quick summary is, very, very low expenditure on health. 1.2% of GDP is shockingly low. It still shocks me to read that. The life expectancy is 5 years lower than the world average, and 40% of the malnourished children in the world live in India. The private sector is 64% of all hospital beds now, and 80% of doctors. And for hospitalisation, the average patient pre-COVID was spending 58% of their annual income to use hospital services, and 40% of those in hospital borrowed money to cover their expenses. And at least a quarter of those who borrowed money ended up in poverty as a result. The government now does aim for universal healthcare via insurance, but less than 20% of the population have any state-backed or private insurance. And that situation, I think, is a direct reflection of not just the commitment to neoliberalism, but also the engagement of the multilateral development banks, which is the focus of this paper. And so the banks started funding projects in the 80s, but very few. They take off in the from the 90s to the mid 2000s, when health was an extraordinary 30% of commitments. But, you know, these weren't great projects, plagued with corruption, privatisation, and the bank's vertical disease specific model of who should get, you know, of what kind of healthcare the poorest should get. The vertical disease specific projects with, you know, TB, HIV, AIDS, malaria, child and maternal health, the minimal package of care. And then they move into the universal healthcare via insurance agenda. The IFC gets involved, as Anna was talking about, in Indian healthcare in the 90s and really expands it in the 2000s with loans for private hospitals and pharma. The research covers the ADB, the Asian Development Bank, the Asian Infrastructure Investment Bank, and the New Development Bank. The latter two just very recent. The ADB starts to get involved in healthcare in a really limited way in around the 90s. And it was a tiny percentage of their program, but you do see lots of TAs, technical assistance projects to promote privatisation and public partner PPPs. So this is the research. So we aim to evaluate what kind of approach the MDBs were taking. Were they going to, in the face of this pandemic, was it critically reassessing their models to respond to the pandemic, business as usual, or using the Naomi Klein's idea of disaster capitalism? Did they exploit the pandemic as an opportunity for mass privatisation? And we looked, as I said, at the loans, or I looked at the loans from all of those four biggest, they're the four main multilateral development banks that lend to India. And you can see these are just the big loan projects. I also looked at all the smaller ones as well, but these are just the big ones. The ADB was the CARES project, and that they co-lent with the AIIB, I think they're both co-lent with the AIIB. The World Bank Group also co-lent with the AIIB, the Asian Infrastructure Investment Bank, under their COVID-19 emergency response and lending program. And then the New Development Bank also had $1 billion loan in there as well. So the analysis, to jump straight to the analysis, it wasn't really crisis, which is, I guess, you know, disaster capitalism response, as you might have perhaps expected. What I really think was what we saw was business as usual. And that meant that the response wasn't strong enough. They didn't really think about how the pandemic was going to impact in that context. And they just continued, you know, there were odd little things like just the continuation of random elements of privatisation and PPPs. Yes, we'll do this loan, but you've got to, you know, this big complex $1 billion loan. Oh, but you've got to tender out this little section over here, or privatise this little bit over here. And, you know, it was all very, very strange stuff. And so what it ultimately did was favour commercialisation and privatisation in healthcare, because the majority of beds in India are in this private health sector. And to respond to it, they had some of that fund had to flow through to the private sector. And when you first read the loans, it sounds like they're supporting the public sector, but you get to page 52 and there's this little statement about, given how many beds are in the private sector, the surge funding will have to see money going from these loans going to the private sector to address the crisis. So the bank loans, and that was the World Bank loans. And then, of course, there's also the IFC loans going directly to private providers. I'll talk about them in a moment. And some of those private providers in India needed this support to keep them afloat, because the crisis had hit their profits. Medical tourism stopped, a lot of elective surgery was cut down. So it was hitting their profits hard. At the same time, the loans didn't address all the issues that Anna outlined in her presentation about private providers, price gouging, poor standards of care, rejecting patients, and so on. There was no requirement that patients not be rejected, for example. There was a high level of funding for the IFC and private sector, and that's a particular concern because of the lack of, again, the lack of conditions around access and the lack of transparency. And the same as in your research, Anna, lots of these COVID response loans going to financial intermediaries where it's really, really difficult to trace where the money's going. Although there was surge funding going to the private sector, we don't know. But I was just reading today a study from Garg et al. On Chhattisgarh that indicated that actually in that state, 69% of COVID patients ended up in the public system. Most of them, I think the private system was even rejecting them. They were only 35% of patients, and I'll come back to the one to that in a moment. The health insurance system that the government and the World Bank have been promoting or the bank's been promoting for a decade was really quite useless for rural people because there aren't private hospitals in many rural areas, and it leaves people with large debts, and that's very expensive indeed. That study from Garg et al. Demonstrated that out-of-pocket costs were just 4,871 rupee in the public hospital and 169,503 rupees in the private ones. And that 59% of private hospitalizations from COVID resulted in catastrophic expenditures, meaning a really high rate. Am I out of time, David?
Susan, yeah, you are
I am.
pretty much on the edge of time. So if you can just
great.
speed through it.
Yeah, so, lack of attention to inequality, to rural and urban, to class, caste and agenda. And I think just this continuation of a neoliberal narrative. I was going to jump over this slide anyway. We just had a wonderful session on the ashes. Where my research is going now in 2 minutes is just, I'm also interested in the way that other World Bank loans are reinforcing the financialization of the healthcare sector, in particular, big loans in India from the World Bank in particular, but also a bit from the Asian Development Bank to the micro, small and medium enterprise sector. 99% of that is micro enterprise, and we know a lot of those loans go to support consumption. So I'm trying to track in this slide the various ways that the development banks are funding the financialization through private intermediaries, whether it's directly through the government, indirectly through financial intermediaries, and then also through the non-bank financial corporations that people are borrowing from to pay their health debts. So that's it, the conclusion. Business as usual and a shift to a private healthcare system. Sorry, I was too long. Thanks.
It's okay. It's very tight timing for everybody on these things, but we've only got so much time left. But thanks very much for that, Susan. That's very interesting and highly relevant research. Can we move on? We'll move on now to ask for Dr. Dhananjay Kakade, who's the head of Saathi. And I think Dhananjay can best introduce the work of Saathi himself, and he's going to talk about that. Dhananjay, you'll let me know if you want me to share the PowerPoint or if you'll be doing that. But over to you.
Hi, can you hear me? I just want to confirm first.
Yeah, we can hear you very well.
Yeah, thank you so much. And it's indeed my privilege to speak to all of you. I'll really request David, if you can just show the slides, because there's some issue with screen sharing.
Sure.
And thank you so much, Anna and Susan, for giving a good overview of Indian health system, because I'm now confident that I will be able to finish my presentation in 11 minutes. Otherwise, I was a bit fearful that I might have to comment on what exists in India. One second.
Is this? Okay,
Yeah,
can
that's
everyone
correct.
see that? Yeah.
Yeah. So if you can go to slide number 2, David, please.
Yep.
Yeah, so this is something that Anna and Susan has already covered, and thank you so much for providing a brief summary of what exists in India. So I'll go on slide number 3, please, David.
Excellent. Yeah.
Yeah, so besides the death and the misery and mortality that we have witnessed during the pandemic, one thing that we got the attention of media here, as well as general, I mean, people have really faced the brunt of overcharging during the pandemic. And for the first time ever, governments were forced to actually introduce rate capping in various states. In fact, there were 15 states who have issued orders about rate capping, and Maharashtra was one of the first state. And Maharashtra is a state where I'm staying. The Maharashtra state has passed a directive on May 21st, 2020 to all hospitals, saying that 80% of their operational bed capacity will be regulated by rates provided by the state. And of course, though the fact is that 15 states have issued similar orders, the impact of these orders were highly different in different states, largely dependent on the political will and sympathy of a bureaucracy. In Maharashtra, of course, it has achieved a different kind of a success, and I'm going to come to that in a minute or so. But why these actions are important? Because for once, there has been a serious attempt by the state to reclaim its legitimate and yet shrinking space, role in the health governance. Despite the fact that overall tendency of the government has been largely toward privatization and corporatization of the healthcare, even state was simply not in a position to ignore the crisis of healthcare, and the elected representatives were aware that it might have a electoral consequence if this thing is not tackled. And that's the reason this rate capping order was passed. Of course, these measures were hugely inadequate. You have to keep in mind that we are dealing with a deeply entrenched phenomenon of states' inability to not being able to rig the private sector. We are talking about last 30, 40 years. So it's not going to go away with a single pandemic, but at least it provided optics that for people as well as who were critically dependent on private healthcare, that there's some action that government took, and it certainly sort of gave some degree of confidence to people that if they go to the private sector, then probably the sort of absolute exploitation that is taking place might be restricted to an extent. Yeah. Next slide, David.
Yep. Let me see if I can get this right. Yeah, is that the next one, or did I miss one?
Yeah,
that's the next one.
You missed the one.
Yeah.
So there were two notifications that the state government of Maharashtra has passed, and as per the order that was passed by Maharashtra government on 21st May, the daily rate of COVID treatment were fixed to be not more than 9,000 rupees, 7,500 for ICU care, that is without ventilator, and 4,000 for care on routine isolation beds. Mind you, these are rates which also take into account not just the operational cost, but minimum profit. So these are rational rates. And in ordinary times, these rates are highly inflated, but these are the rates that government of Maharashtra has stipulated. And from 1st June 2021, based on division of areas of the state into category A, B, and C areas, essentially urban and metropolitan areas like Mumbai and Pune are in category A. Then there's a tier B cities and there is tier C cities. So maximum daily rates for COVID care remained same in category A areas, but were reduced for category B and C because these are essentially peri-urban and rural areas. So this is how a rate capping has been initiated. And I must also say here that this is not an action that was initiated by few sympathetic bureaucrats, but the hue and cry that was witnessed on the streets of India, the kind of media reports that were coming. They were simply not in a position to ignore that. And that's the reason these orders were passed. Now next slide, please, David. So this is an interesting slide where we have tried to show the scale of overcharging in the state of Maharashtra. So in effect, the maximum amount that was chargeable even in tier A cities was not more than 9,000 rupees, which is around 115 USD. So you will see between this 10,000 rupees, which is close to $115. Anything beyond 10,000 rupees is all overcharging. We have surveyed more than 2,000 patients, 2,579 to be precise. And out of that, 1,954 patients, which is 75% of total cases, have experienced charging. And compared to the official rates, we should have been charged as per regulations. And this is the survey that's been conducted by Corona Ekal Mahila Punarvasan Samiti and Jan Arogya Abhiyan. Jan Arogya Abhiyan is a PHN Maharashtra chapter. This is sort of overcharging that took place despite the fact that the government has issued a notification for rate capping. It also points to, private sectors sort of assumed immunity against any government action. And these overcharging cases subsequently were documented and presented to the government. In many cases, on an average, 2,270 USD per day were charged by private hospitals. Mind you, this is a catastrophic expenditure for poor household, and it effectively also means that their financial planning for next 3 to 4 years is going to be disrupted. And during COVID, people were not just, obviously many people went to the public hospital, but in scenario where public hospitals were not able to fulfill that need, they have no other option but to go to the private hospitals. Next slide, please, David. What we did afterwards is audit tax bills. And this was a deeply contested arena of this advocacy because private sector lobby to a great extent opposed this initiative to thumbnail. Essentially, the sort of a power asymmetry that exists between patients and private hospitals and professional lobbies of doctors was too acute. But despite that, we have managed to audit this excess bill. So Jan Arogya Abhiyan, PHM Maharashtra prepared standard complaint form on COVID overcharging and conducted online training for activists to fill the forms. And there were more than 480 complaints that were submitted to state government for further audit and recovery. And Saathi gave technical inputs and guidance to complaints in preparing for audit process. And during this entire process, there was a rigorous state and district level follow-up to fast-track the audit process. On this last point, I can go on, and perhaps it will require a separate conference about how every step was extremely difficult to execute, because we were not just dealing with the backlash of the private sector, but also the inertia of bureaucracy. They have never done something like this before. Yeah. Next slide, please. Though this success might look moderate, but hugely significant. There were 50 plus overcharging complaints were resolved successfully with approximately 16,900 USD related to complainants. And in my opinion, and correct me if I'm wrong, but this is probably for the first time in the world where private hospitals have returned the money to the patients. And this was a different kind of I'll say, social action and struggle. And this process is still continuing. In a way, this also gave us a confidence that if there are mechanisms to seek a redressal, and if there is an interlocutor between community and these monolith structures like regulatory bodies, then probably we will have a success at the end of the tunnel. And it was a deeply tiring process. It was also emotionally traumatic because we have to hear about financial exploitation that has taken place in institutions where people went to seek care. Yeah. But at the end of the day, this is the success that we have got. Next slide, please, David.
Yeah.
So lessons for once the class boundaries that restrict horizontal relationship between different socio-economic groups. Mind you, even the middle class of India suffered a lot during the pandemic, and we have to find. I mean, unfortunately, and let me be very blunt here. Most of the academic discussions of financialization and marketization tend to be prognostic without being solution oriented. And if we have to find a solution, we will have to have narrative that emerges from patients. And among many regulation related aspects, one that is vitally important for our patients is overcharging. There's also a need for patient-friendly time-bound grievance redressal mechanism. That's one of our key lessons. One more thing which was extremely difficult for us is the collectivization of affected and aggrieved patient and families. As such, there was no constituency of COVID patients, unlike what you would have seen in, say, HIV and other instances. Focus was not exclusively on getting refund, but also to create popular narrative on profiteering tendencies of private and corporate hospitals. Thus far, there have been more than 100 articles that have appeared in local media about profiteering and how private sector has exploited patients. And even while speaking to ordinary people on street, one gets a glimpse of that simmering anger about these corporate and private hospitals and how they exploited people. So I'll also like to add here that one idea really resonates with people, or the idea that is at a level of perception, what really appeals to people is a term overcharging. Nobody understands universal access to healthcare. Nobody understands, for that matter, even patients' rights. Sometimes I don't understand USC, but that's a different story. But you have to really go to patients in order to understand what is their narrative. Next slide, please.
Okay. Dhananjay, can we aim for a minute, just a couple of minutes, please?
Yes. I'm finishing in 2 minutes. As Saathi published this compendium, Patients' Voices During Pandemic, you can access that on Saathi website. It covers 23 cases, their stories and analysis of their rights. I'll again come back to how the narrative has been building. We got a sense that people have intuitive but a strong understanding of profiteering in the health sector, and that's our hope, that we will be able to have a campaign where people will be able to sort of question unaccountable, non-transparent behavior of these institutions. So without going too much into details and sort of narratives, I suppose this is where we are standing at the moment. My last slide, perhaps. David, next, please.
Yeah.
But the paradox of post-COVID health system and policy making. A strong case is made for public sector, but in practice, a push is for further privatization and commercialization for healthcare. And despite being overcrowded, just to put this point very briefly, private and corporate sector, which accounts for total 73% inpatient facilities in India, catered to less than 10% of total COVID-19 cases. Many cases actually went to the public hospital, which is underfunded, underfinanced, and of poor quality. People have no other way to actually seek healthcare. Whole thrust towards private sector and commercialized purchase-based framework of healthcare failed spectacularly during COVID epidemic. And that's one of the lessons. Unfortunately, Niti Aayog, which is apex public policy think tank of Government of India's report on investment opportunities in Indian healthcare, strongly advocates for venture capitalism and private equity investment. And this is a sort of a Trojan horse that we have, and we don't know how to tame this. And that's the reason some of these local narratives need to link with the upstream determinants of what is happening in countries like India. How do we bridge that gap is a question. What are the essential public health characters that any health system must retain under the onslaught of privatization? That's a question that is really emerging during the COVID-19. And now, really, my last slide, David. I'll 30 characters. So, linking patient stories and local campaign with upstream determinants of marketization. Private sector accountability deficit as a theme has begun to resonate. How to tap this opportunity to communicate more significant and health rights narrative. This is opportunity of our time, and we ought not miss this. Thank you.
Yeah, fantastic. Dhananjay, thanks so much indeed. I was accelerating you just because of time constraints generally, but I mean that's wonderful because you both given a story of real hands-on getting into the process and audit, and also delivering a concrete result, and also turning that into active narratives, and all of those things are lessons and opportunities for all of us, I think. So thank you very, very much for that. We're now going to go to Deepika Joshi of the public health movement. Deepika, would you like to unmute yourself and start presenting the case? Thanks very much.
Do you see my screen?
Yeah.
Yeah. Okay. Yeah. Hello, everybody. And yeah, I am Deepika from People's Health Movement. Thanks, David. And thanks to all the organizers. So basically, my presentation is around this case study that we had done recently in Chhattisgarh, state of India, around the deprivatization of one of the heart institutes in the state, and how basically and how it can serve as a model for other such initiatives in the country, and basically how this example challenges the myths around the public health sector. So So this is the state. It's in the central east part of India, and it's one of the new state which was founded in 2001. So immediately after the state was formed in 2002, the government thought of coming up with a high quality cardiac institute, which was supposed to provide tertiary level cardiac services to the people of the state. And it was set up within the biggest hospital in the state, in the capital city. And so the idea was that this will be the end referral points for all the patients in the state. For 15 years, this public-private partnership worked. This was done between the state of Chhattisgarh and Fortis Escorts, which was a private group, to provide these cardiac services. And after 15 years, in 2017, amid reports of underperformance and non-fulfillment of contracts, the Chhattisgarh government decided not to renew the contract and handed over this tertiary care cardiac institute to the state government. So our idea was basically to to document this experience and derive learnings from it, and also see how it can serve as a model elsewhere for such practices elsewhere. Yeah, okay, I'll go to findings directly. So this is basically the timeline. The public-private partnership with Fortis Escorts ran for 15 years from 2002 to 2017. In 2017, it was the partnership was terminated, and in between there was a time period when the government was also running its own government cardiology unit and trying to provide services via its own sector. So what were the reasons for deprivatization? One major reason that the administrators and the government servants told us was that this partnership failed to fulfill the MOU conditions itself in the first place, and the terms and the terms and conditions under which this partnership happened were not being fulfilled, and even the government was not happy with the running of this institute, and also there was this understanding that it was not able to serve the people of the state despite receiving subsidies from the government. It was built on it was running on a government land, and a lot of government services were being used for running this cardiac institute. The second reason that enabled this deprivatization was how the administrators and the people who were involved in this process were also running a parallel unit within the government sector, and showing that how it was performing as well without any interference or without any support of private sector. So that parallel unit that was being run by the government in the government hospital served as a model, and also provided a rationale to show that the cardiac services can be delivered by the government health system as well. And I think we also thought it was very important to note that it was the decision to terminate the contract, or to decide the decision to continue running the cardiac provide cardiac services through the government rather than the private was not a random administrative decision, because the people came with a certain political understanding that health is a public good and which is to be provided by the government. And the last important reason to highlight is the political climate in the state. The deprivatization happened during the last of the term of this right-wing government in the state. And even though the deprivatization happened during by the end of that government's tenure, it was the next party which contributed to its success by providing the necessary resources and aids. And it's also important to note that the new party that came to power came on a progressive manifesto, which was different from the previous right-wing party. It came to the new party came to power with a progressive and socialist-leaning manifesto, and which talked about public healthcare and public provision of services in general. So these were some of the reasons which helped in this deprivatization process. A lot of what I'm going to speak next is actually a lot of us will be knowing anybody who's used the private and public sector, but nonetheless it's important to list them out. What were the differences? What were the differences that we saw between the public-private partnership that was running for 15 years as opposed to what today is the government-run Advanced Cardiac Institute? One is definitely the cost. Escorts, the PPP remained a profit-driven entity. In the MOU, it said that it could fix or schedule tariffs without any limitation, and that is how it functioned. While today ACI provides services without, the government-run ACI provides services without charges or at subsidized rate. The type of patients who have come is vastly different. Earlier, it would be only middle class or an upper middle class strata who who could take services in the public-private partnership run hospital. But today we see that people from all kind of socio-economic backgrounds come to the hospital, and from all over the state, and not just the big cities, because there is this expectation that if you go to Raipur, or if you go to hospital, you will go to this hospital, you will be provided these services. In terms of services, the private sector, the private partnership provided very limited range of cardiac services, while on the other hand, the government unit today provides much larger range of services and even much higher end range of cardiac services. And many cardiac surgeries in the ACI are the first to happen in the state, which is usually not the case, because you usually see these high end, there is this idea that these high end advanced surgeries or procedures happen only in the private sector, which is not the case here. The public-private partnership had no links with the larger health systems, but today we see that the government-run ACI has plans to train the nurses across the state at the secondary level, who could provide, district level or sub-state level services in cases of cardiac emergency in the state. So it plans to serve as a resource hub, and the health workforce. As is expected in the private sector, there was no expectation to follow the constitutional provisions for affirmative action, which was to provide quotas for the historically underprivileged, while the government-run institute is providing these services. What does this mean? I'll read from the slide. So such specialized services in government sector, which is the ACI today, are not taken for granted in a country like India, where public health system struggles to provide basic health services amidst underfunding and neglect, and especially benefits the poor who may not have other options. So yeah, if you talk to the patients, you could see the kind of satisfaction in their narratives, because it's not usual that they come to a hospital and very high-end services which they thought were otherwise only available for very high charges, or big hospitals in big cities, were provided to them in a government setup in an equitable manner, without any money being charged to them, and with good behavior from the staff, or without any exploitation. So the patient testimonies brings it out more clearly about that kind of satisfaction from the government-owned institute. And the second important thing would be breaking the myth about health services in India, that quality and high-end tertiary care services can only be provided by the private sector at a high cost. Therefore, the emphasis in our findings that even though these procedures are free of cost in the government facility, the quality of services is not compromised. Sorry. Yeah. To end this presentation, I will highlight that the equitable. So one major, to sum it up, to sum up that comparison slide between the two institutes, the government-run institute was providing much more equitable health service provision, be it in terms of cost to the patient, be it in terms of behavior, in terms of the services, in terms of the treatment to health workers, and so on. Quality provision of health services in public sector is possible with willing political and administrative leadership, and ACI is one example of that, as we saw in the state and the political context that I gave earlier. And lastly, governments should not and cannot hand over crucial and life-saving health services for private sector and expect it to serve public interest, let alone of the poorest. That is where I end my slide. Thanks, David.
Deepika, thank you so much. That was vivid and brilliantly encouraging and detailed case study of one of the great victories that we've heard about during this conference, and demonstrates precisely that the the model of public sector healthcare does work and deliver, and that working on both making it operate effectively and effective constant political campaigning can lead to an end of PPPs and a transfer back to public healthcare. So thanks very much indeed for that. We're now going on to hear effectively two presentations on similar studies. The first one is from Sourindra and Ghosh from Council of Social Development in New Delhi on the effect of publicly financed health insurance on the characteristics of inpatient care in India. The title, I think, speaks roughly for itself, but Sourindra, very much looking forward to this. Please go ahead, over to you. Again, if you can keep to 15 minutes, that would be great. But thanks very much indeed for speaking.
Thanks, Professor Hall. And I'll start with sharing my screen now. Visible?
Yep, that's fine.
Hello, everybody. In this presentation, I will talk on the impact of publicly financed health insurance on inpatient treatments in India. So this publicly financed health insurances, or PFHIs, where government pay on behalf of patients for public and private inpatient care, were floated in India by the central government and by several state governments in around 2007-2008. And these are only for inpatient treatments, with exceptions for a few outpatient procedures, and mostly targeted towards the poor. We have already heard from the others that the general policy consensus, particularly in the last 2 decades, have shifted more towards private-public partnership and away from the commitment to build a comprehensive primary healthcare system in India. Assuring coverage of high health expenditures through PFHIs is a part of that strategy shift. The questions that I will address in this presentation are there are primarily 3 questions. The first, in the context of growing privatization of healthcare in India, does PFHI cause a further shift towards private care, squeezing the public sector? The second is whether PFHIs induce the private sector to treat relatively severe and complicated cases, or do they cherry pick easier cases compared to the public sector? And lastly, whether PFHIs ensure better quality of care, and is there a differential impact for the public and private hospital? So the data that I will be using is the NSSO Household Health Surveys data. The PHFIs were introduced in 2007-8, and I am using pre-PFHI data and post-PFHI data. So 2004 NSSO health round for the pre-PFHI period, and 2014 for the post-PFHI period. I have used difference in differences, which is the difference between the changes in treated and the control groups over the pre and post-treatment period is interpreted as the possible effect of the treatment. Here, the treatment is the insurance, the PFHIs. So the treatment group, I have defined the treatment group to be the NSS state regions, and these are the state regions are the collection of district categorized by agroclimatic zones, and they have representative samples in the NSS surveys. So the NSS state regions with PFHI coverage equaling the national average. So for India, 12.78% of the population is covered by PFHIs. So the state regions which have this population coverage or above are considered as the treatment group. The population PFHI coverage of the treatment group taken as a whole is 31.6%. I have used 3 control groups to cross-check my difference in difference findings. The first control group are the state regions with PFHI coverage less than the national average. And here the group coverage is 4.1 compared to 31.6% in my treatment group. Control group 2 is defined as those regions having less than 5%. So I've restricted, I've reduced that that cutoff. And the group coverage reduces to 2.2. It changes our control group compared to the first one to a great extent, reduces the control state regions from 54 to 38 and reduces the sample size by 1/3. So I am using different control groups to validate my results, whether the results hold or not. So this is basically using low treatment groups as control group in a difference in difference setup. Control group 3 is basically the control group 1, but I have excluded all the PFHI enrollees. It makes the control group 3 free of any effect of PFHI. However, it can compromise representativeness of the control sample, that we have to agree. But if the results are very similar across these 3 control groups, which I will show, we can say with fair level of confidence that the results more or less show the absolute effect of PFHI in the treatment regions. So I will focus on the following states. And these states are the major states which come under our treatment group, that is the major states with at least one state region where estimated PFHI coverage equals the national average or more. So there are 8 such major states: Rajasthan, Gujarat, West Bengal, Odisha, Chhattisgarh, Andhra Pradesh, Kerala, and Tamil Nadu. So this is the basic difference in different two time period difference in difference regression framework. I am looking at the impact of PFHI on length of stay of a hospitalization period, which will give us an idea of utilization of healthcare services. Second, I will look at the impact of PFHIs on probability of admitting to public hospitals. And last, I will look at the impact of PFHI on the probability of admitting in paid ward. And so this last one will give us some idea about the effect of PFHI on quality of care, though not in a strict medical sense, but the paid ward would have generally better facilities and comfort. So these are the difference in difference equations. Now there is one time dummy, which is 1, which takes value of 1 for post insurance period and 0 for pre-insurance period. There is a treatment dummy, and the interaction of the time and treatment dummy, the coefficient of that interaction is basically the estimate of the impact of PFHI. I have also seen public.
Sourindra, sorry, can I just interrupt? This isn't a technical economists meeting. Maybe we can skip this. So
we can just skip this.
Thank you.
Okay, so I will go directly into my findings. So this is and I will highlight my major findings. So this is the effect of PFHIs on length of stay in a hospitalization period. And if we look at the first row, the aggregate, so the treatment regions taken as a whole, we can see that in the public hospitals, PFHIs has increased length of stay by 2 days, and this is statistically significant. So we can more or less rely on this result. But in the private hospital, it has not done so. And if we similarly look at different regions, so we can find in 9 regions in public hospitals, the length of stay has been increased due to PFHI, compared to only 4 regions in for private hospitals, and in two regions actually, PFHI has reduced length of stay in private hospitals. So this table shows the effect of PFHI on probability of admitting in public hospitals, and we can see that in many regions, like West Bengal, regions of West Bengal, in Chhattisgarh, in Gujarat, some regions of Andhra Pradesh, a region in Tamil Nadu, it shows a reduction of probability of admitting in public hospitals. And this is more among the non-poor than the poor. This table shows the effect of PFHI on the probability of admitting in paid ward. So, and the public versus private results show up a interesting picture. taken the treatment regions taken as whole, the aggregate column row. In the public hospitals, PFHI has increased the probability of admitting in paid ward, whereas in private hospitals, it has reduced the probability of admitting in paid ward. So it's opposite. And if we look at the regions, there are 6 regions where in public hospitals the probability of admitting in paid ward has increased, and much less in private hospitals. And in fact, in 3 regions, the probability of admitting in private hospitals in paid ward in private hospitals has reduced due to PFHIs. These are the comparison of DIT across the control groups, and I show that they're actually identical, so the results are believable. So there are 3 takeaway points from these results. The first is that there is a shift towards private care, particularly in West Bengal, Tamil Nadu, Odisha, Gujarat, etc. Probably financial protection given by PFHI, neglect of public care, and some design issues such as fewer empaneled public hospitals under PFHIs could be factors behind this shift from public to private. The second takeaway point is there is probably a shifting of burden of severe cases to the public hospital. So we have seen that there is increased length of stay in public hospitals by 2 days. It is statistically significant at 10%, but not in the private. Actually in 2 regions in private hospitals, PFHI reduced length of stays. Now, given that public hospitals have low excess capacity, increase in length of stay is less likely due to overuse or over treatments. The plausible reason could be the PFHI covered patients with more severe diseases and hence requiring longer length of stays are moving towards public hospitals, while private are probably cherry picking on the less severe and easier cases. And the third takeaway point is that PFHI enables better care in public hospitals, but not in the private hospitals. So in short, we know the criticality of public sector, yet PFHI is causing a shift to the private, marginalizing the public healthcare. While benefits of PFHI are more actualized in public hospitals, severe cases are going more to the public hospitals, while private are probably cherry picking the easier ones. And also improved access to better care through PFHI is ensured in the public but not in the private. I will conclude with this following remarks. So there is no historical evidence that such restricted and targeted PFHI model is a step towards universal healthcare. And one cannot help but noticing that the basic structure of India's publicly health insurance model, which the others have also mentioned in their presentations, it appears to be in many ways similar to that of the US. Now that US experience have shown that it does not adequately provide care to the patients. It leads to over specialization and experienced rapidly escalating costs for both government and patients. So I feel that this is a flawed model to achieve sustainable, affordable, and quality universal healthcare. To achieve that, India needs to fulfill its commitment to building a robust public healthcare as a tiered referral system of comprehensive primary healthcare. Thank you.
Sourindra, thank you for that, and thank you for such a technically detailed survey. And you're presenting the results in a very clear way and with very clear and definite conclusions. It's quite shocking, as you say, that any country should look at the international statistics on the comparative disadvantage of the US system of healthcare and decide that, yeah, we want to model our future on that. Very interesting, and thank you very much. Okay, we now have a final contribution coming from Sulakshana Nandi. Sulakshana, welcome, and thank you very much for agreeing to present. Sulekshana was in fact also involved in the study presented earlier by Deepika, but I think what Sulekshana is going to present is something, well, she's already presenting it, so I'll shut up and carry on and hand over to you. Off you go, Sulekshana. Thank you.
Yeah, thanks so much, David. And I think thanks to all the presenters who've come, before me. I think this, I think this presentation will basically be a sort of a coming together, amalgamation of some of the themes that we have discussed today in our presentation. And even though I have a lot of slides, but I will make it brief and I'll share the slides for everybody to go through it, go through them in leisure. So just first of all, acknowledgements from colleagues and comrades who have worked with me on this, and including many people who are in this room today. Just a brief slide on, how the National Health Insurance Scheme started in 2009, the RSBY, and then it got expanded into the PMJY, just to sort of familiarize everybody with some of the nomenclature. So the design of publicly funded health insurance schemes in India and the assumptions, and it's in a sense also, much sort of influenced by the global narrative on universal health coverage, like Anna also mentioned. So when we look at the traditional sort of the health systems design in India, what was it that was different? So firstly, there was a purchasing mechanism or a sense of contracting the private sector, giving choice to the patient, and and have really an extensive IT systems on which this thing runs on. The assumptions in this that have been made by the government, by the policymakers, is that strategic purchasing through the PFHI schemes will really is the way to regulate the private providers, especially the for-profit private sector, and that the choice to patients will ensure accountability. The IT systems will take care of fraud, and the market competition will take care of the rest. But what we actually see happening, as really illustrated by the presentations that came before me, is that there's provider and regulatory capture by the private sector and the corporate sector. Contracts between the government and the private providers are not being enforced, and the most vulnerable, the patients are being pitted against the most powerful, who the doctors lobby, the for-profit corporate private sector lobby. And there's a collusion between public and private sectors that has been legitimized through such a scheme, and there's lack of equity access and financial protection. And I'll just briefly go through these points just to sort of map out the issues in India at this time. So just sharing a patient's narrative from one of the studies that I did as part of my PhD, in which, and actually this is one of the hospitals that Anna was talking about, one of the corporate hospitals that's got funding by, one of the government, northern governments. Despite being enrolled and utilizing the insurance card when the child was admitted, once the hospital kept asking the family for money, and once they ran out of money, the doctor basically abused them, and they had to really take a lot of loan, and they had to sell a number of their resources to pay for the hospital. Similarly, I mean, these narratives, of a patient who's, these are some of the kind of, strategies that the for-profit hospitals basically employ to ensure that, patients are not able to get discharged at their own free will or get referred to other places. So what I want to emphasize in this case and the study is that, families and the patients exercise the agency to the extent that they could. So it wasn't an issue of lack of awareness. And often when we have policymakers, academics, global health experts talking, who sort of promote this kind of insurance. They keep on harping on about awareness, but all these families were very well aware of what their entitlements were, but they were also aware that in a for-profit private sector or in a corporate sector, it would be impossible to, utilize the publicly funded health insurance without any out-of-pocket expenditure. So they kept negotiating, they kept arguing, but finally, after a point of time, because of the sensitive situation or of the patient's condition, they really they were not able to fight, and they had to, to that extent, and they reduced some amounts, etc. But it wasn't cashless. So one of the women that we spoke to, said that it is like a goat has been trapped, and the government really just takes puts that goat into the the private sector, like an alliance cage kind of thing, and they will the private sector ensures that they sacrifice the goat. So some of the evidence that even Sourindra was talking about on the quantitative surveys, the qualitative studies, and other research, and I'm sorry I did not put the references here, but I can always share the references for all and the data for all these points. So I'll just go through some of the points from the evidence that has emerged on PFHI schemes in India. So firstly, private sector hospitals are unequally distributed, and they're concentrated only in a few cities. So that also means that claims are happening very concentratedly in a few places, and especially when you have unequal services in the more remote and poorer districts, it's in a sense the population in those districts are subsidizing the better off districts and people, because you have in a sense allocated insurance funds of premium equally for the population. Utilization has been concentrated on a small set of services in the for-profit private sector. That Sourindra was also talking about, and a pattern of unnecessary hysterectomies and other procedures. So this is just a graphical representation of the hospitals. The red are the private hospitals, which you see is concentrated very much in the middle of the state, where the state capital is, and the rest are the green are the public sector hospitals that are equally distributed across the state. But because it is the private sector that's utilizing the insurance scheme so much, so a lot of the money is being concentrated there. So it is in a sense, so your most vulnerable areas are really not getting the services, because the money, we will go on to that, on how the public sector in these areas are being affected due to the insurance scheme. So in terms of financial protection, again, like my preceding speakers talked about, they have not kept, the scheme has not led to cashless services. There is extensive extra billing by for-profit hospitals, and leading to out-of-pocket expenditure, and in many cases catastrophic health expenditure. And there is a case study which I will not go into, but it was of an indigenous person from the particularly vulnerable tribal group, who basically was sort of jailed, and in the hospital they were held at the hospital till they could pay the money. So now, I think for all of us here, one important thing we need to consider is the impact on the public health system. One, we are seeing that a lot of concentration of the claims is in the cities, in the main urban centers where the for-profit private sector is. As a result, the funds are diverted to the private sector, and because they're also taking a lot more of the claims, and also selectively selecting the kinds of diseases or conditions they want to treat. So even under PMJY, we see more than 75% of the claims amount going to the the private sector. So in a sense, again, like I said, resource transfer from the more needy areas to the more urban and more developed areas. And funding for PMJY has led to simultaneous reductions or stagnation in very significant other public health programs, whether it is on public health infrastructure, hospitals, on reproductive and sexual health care, on maternal health, on communicable diseases, and various other public health programs, on TB. So when you look at the political economy of this whole thing, one important thing is to look at how this scheme has legitimized collusion and regulatory capture. So the dual practice by government doctors that was already happening, that's also increased, and because you would rather refer them to your private nursing home, and get the insurance claim rather than treat them at the district hospital where you're posted. And the collusion between the private and the public sectors have increased, and all these have implications for regulation purposes. The National Health Authority, that has sort of been formed as a purchasing agency, mainly bypassing the Ministry of Health, really has made a lot of partnerships with for-profits and their advocates. The World Bank and the Gates Foundation, etc., have been involved from the time of designing it, to implementing, to research, to publications on these things, on this issue. So basically legitimizing the involvement of for-profit and corporate sector in government policy making. And non-transparencies, again, is a very huge problem that we are facing with the PMJY, because the National Health Authority claims that it does not have data, and that you go to the states and get the data, whereas it is it is a NHA that basically handles all the data, and they are the ones who sends the data back to the state. In fact, states get data sheets that have like blackened out rows from or names from the NHA, but when you file a right to information application at the National Health Authority, they say you don't.
David, you are mute.
Okay, thank you. That was an unexpectedly abrupt ending, which I assume was not intended by Sulekshander. I should just see if we can get...
Yeah, can I just continue? I'll just finish it soon.
Yes,
in just
please.
about 10 minutes, 11 minutes into the presentation. Yeah. So
we don't have 10 minutes left, Sulekshander.
No, not 10 minutes left. No.
Okay, fine.
No, I'm saying I'm nearly,
no, please do.
it's done. Yeah, so I don't know whether, you saw the slide. I will not go into the details. So the other aspect of regulation is like this is an example in which, in Karnataka, the purchasing agency actually has the corporate hospitals on board, including, some of the ones that Anna was talking about in her first presentation. So basically the to be regulated becomes the regulator. And this scheme, the PMJY, is very clearly being marketed as a business endeavor, and these tweets are from the previous head of the National Health Authority. He's no longer the head, but this is how the marketing has been done. Did the PFHI schemes help India during COVID? I think Suzanne has, and Dhananjay has really spoken about it, but just want to acknowledge that it did not. So when you look at other LMICs and, India and the PFHI schemes, so basically what we find is that, private provisioning really destroys all advantages of public funding. And within the universal health coverage narrative, there is a lot of consensus on public funding, on governments, providing funds for healthcare. But when it comes to private provisioning, they are completely silent, which basically paves the way for more privatized ways of provisioning and purchasing. And then we also see insurance coverage without financial protection. So again, the issue of care without, coverage is there, but it's without care, or without actually people being able to receive health services, and also having to incur out of pocket. And so insurance as a mode of financing and incentivizing has certainly not worked in the public sector, and it's certainly has exacerbated problems in the for-profit private sector for people. And can the so I just wanted to give you an example. I will not go so this again a study that I did with the WHO, and we've been documenting the set of sort of improvements, reforms, changes that have been happening in the southern part of the state that I live in Chhattisgarh, which has been affected by long-term conflict, armed conflict between the state and the Maoist groups. And slowly now the health system is being rebuilt, revitalized, and we have very we do have a lot of excellent work going on there, and I can share the link to the study. But really, if you look at the impact on human resources and services, it's been really phenomenal. And if such improvements can happen, in a place, which, one of the most conflict affected, places in India. I mean, it can certainly happen in Maharashtra and Raipur and Delhi and other states too. So just to conclude, I think for all of us here, we need to remain vigilant and just do the kind of documenting and scrutinizing the evidence that we've been sharing today, and also examine and critique the dominant narratives, because they are mainstream dominant narratives that really need to be critiqued and with the evidence that we all have and that we all have shared. And of course, higher investment in the public health sector, including expansion of public employment, that's very critical. And all of us here must really build solidarities and shift the normative environment in healthcare from the market-based commercialized provisioning to public healthcare based system. And as health movements, we will continue to document cases, build evidence, and resist commercialization of healthcare. And you're welcome to go to the PHM India website and to the People's Health Movement website, where we have a lot of resources on that from all over the world. Thank you very much.
Fantastic. Tilakshana, thank you very much indeed. That's a great conclusion to a great final presentation. And again, just especially to note the particular encouragement of ending with and spelling out concrete examples of how and where progress has been made and can be made. We've literally got 4 minutes left before closure. Is there anyone in the audience, in the workshop, who has a particular question or point? If so, please indicate by putting up your hand in the usual way. And while waiting for that, if there isn't anything particular, I'm just going to invite the speakers, going back in reverse order this time, to invite them if they've got any quick comments on the overall part of the programme. And then at 14:40, I shall wind it up. So so going back to before Tilakshana was, Tilakshana will come back to you again at the end as well for a final comment. Sourindra, please, any final thought?
Yeah, I just want to highlight or reiterate one point, that that whether at all we want the PFHIs to ensure access to people through further privatization, because that escalates the costs. The private hospitals, private institutions are in a better bargaining power, so they will ask for greater premium in the next fiscal. That escalates cost. Secondly, it distorts the treatment regimen. Without a regulation of private sector, without a referral system of the treatment, it over specializes treatment, it complicates the treatment, it delays treatment, and further escalates cost. So that point I wanted to reiterate.
Okay, thanks very much, Sourindra. Deepika, do you have a final thought to share?
Yeah, no, not much. It was a nicely curated workshop, and I think all these speakers sort of gave us an idea about all the different strategies that we can use for sort of challenging the ensuring public-centered healthcare, whether be it research, be it showing positive examples, be it campaigns that Sulakshana mentioned in the end, and so on. So yeah, I think we all need to, and also including the other session, the previous session on community health workers, very inspiring stories. So yeah.
Yeah. Okay, thanks for that. And so Dhananjay, yours is now going to be the last word, I'm afraid, because we're on 14:39. But it's very appropriate, I think, that you have the last comment. If you can. Can you manage to unmute yourself and speak? Okay. If not, well, I'm sorry about that, but you as everybody else, made a very, very powerful presentation, and thank you very much. Thank you so much to all of you. There's barely been enough time for discussion, but that series of presentations was so powerful in terms of both presenting the alignment of forces, if you like, in terms of international financial agencies, the private sector itself, and the mechanisms through which the private sector injects itself, both gleaning parts of any aid, in inverted commas, on the way out, and then finding itself embedded in the supposed regulatory system once it's operating. So on that level, it was a brilliant description. And the accounts of how, particularly from Dhananjay, of how that the way that system operates can be attacked by very detailed auditing and organization and so on, was very encouraging. And then secondly, how distorting a health finance system is of any attempts to move to universal public healthcare systems. And again, very good to hear positive examples of strategies moving in the opposite direction. So with that, and big thanks again to speakers and everybody who helped organize this workshop and the other workshops in this section, I declared this workshop closed, which means the closure of the Asia regional section of this conference. Once again, the meeting will remain open, and in 15 minutes time, it will reopen in Chile with the first workshop in the Latin American regional session, which these are the only two sessions of this conference which have been adjusted across time zones to suit local interests. So that's why Latin America can continue onwards. But thanks very much to everybody, and well, for sure we will be in touch. Thank you.
Thanks.
Bye.
Bye.
Okay, okay. We're hearing you loud and clear from the English-speaking world. Yeah, thank you. Okay, I'd like to declare this workshop open. Firstly, I apologize for speaking in English, but I'm declaring it open. Sorry, is that okay? Okay. I'm declaring it open on behalf of okay. Maybe I'll start again since everybody's now come. And Pedro, I shall get you pinned in the middle as well, and Esteban too. And when Robertson arrives, we'll put him into it as well. Okay, start again. Firstly, apologies for doing this in English, but I'm opening this workshop formally on behalf of the organisers, University College London and University of Greenwich, who've organised this conference globally with the assistance of partners, academic, union and social movement partners in all countries. The key academic partner in Latin America has been CONICET, represented by Esteban Castro, who's put a lot of work into helping put these workshops together, and with the collaboration of Public Services International, which has also put a lot of effort into organizing a lot of these all of these workshops. The title is Shifting Narratives about Public Services Spending and Provision, because that's a global issue, it's a global political issue, it's a global theoretical issue for economists and political scientists. We are trying to build stronger collaborations between academics, trade unionists, and activists to develop and strengthen these narratives in a way that strengthens the role of the public sector and public services. This particular workshop opens the Latin America section, and it's about Chile, because by any standards, Chile is one place in the world that I think a lot of people in the world are looking at, precisely because progressive narratives seem to be in the ascendancy in Chile. And so we want to understand how that is, how that was developed, what the prospects are, and so on. So that's my formal introduction. I'll now hand over to Pedro Viardi of PSI to moderate the meeting, which I'm fully expecting him to do in Spanish rather than English, which is probably more user-friendly for most people. But interpretation is available between English, Portuguese, and Spanish, so this can be a multilingual, genuinely multilingual workshop. So thank you very much, and I'll hand it over to Pedro, who will say a bit more about the speakers and the plans, and he will introduce the speakers, keep them to reasonable time, and then open the floor to discussion with people being invited to put their hands up using the reaction button at the bottom of the screen. But everybody is encouraged to use chat whenever you feel like it. So you can start now using chat, or use chat when speakers finished. Okay, Pedro, over to you, and thanks very much for doing this.
Thank you, David, for the introduction. Hola, buen día, buenas tardes y buenas noches a todas, todos y todes. Es un gusto moderar ese importante panel. Me llamo Pedro Villardi, yo soy coordinador regional de Equidad en Salud de la Internacional de los Servicios Públicos. Y sin demorar, bueno, quisiera hablar un poco de la importancia de ese evento, justamente por toda la dinámica política de Chile que ha generado dos fuerzas, ¿no? Que ha elegido un gobierno de izquierda y que vino desde de los estallidos sociales, y eso aprendí mucho con Mariott cuando estuve en Chile, que me mostró las plazas, me mostró dónde se daban los conflictos, cómo se movilizaba la gente, cómo se organizaba el pueblo, y fue muy importante para mí estar ahí. Pero también ese proceso ha generado un debate sobre la constitución ella misma de Chile, una constitución heredada desde de la dictadura militar, una constitución profundamente neoliberal, donde no había derechos, donde se preservaban privilegios, y todo ese movimiento que ha generado el pueblo chileno ha podido llegar a un momento de debatir la propia constitución y promover un proceso constituyente. Ese taller, ese evento propone una mirada hacia los desarrollos, esos desarrollos desde Chile, y su relación con los servicios públicos. Y hoy vamos a hablar mucho del tema del agua, ¿no? Yo voy a presentar a los panelistas antes que ellos hablen, y quisiera presentar, iniciando la presentación, de Mariott, que es periodista, licenciada en Comunicación Social y magíster en desarrollo organizacional. Es secretario subregional de los países del Cono Sur de la ISP y coordinadora por más de 15 años de proyectos de formación sindical vinculados a juventud, género, salud, trabajo decente y servicios públicos de calidad. En su país de origen, Chile, ha participado activamente desde la década de 2000 en campañas nacionales a favor de los servicios públicos de calidad y trabajo decente para las y los trabajadores del Estado, y en ese último tiempo en el proceso constituyente a través de la presentación de la Iniciativa Popular de Norma, que logró reunir casi 17.000 firmas de 15.000 que se necesitaban para incluir en el texto constitucional los servicios públicos universales de calidad y su financiamiento. Naire, por favor, entre 10 y 15 minutos, te agradezco la atención al tiempo y por favor, tienes la palabra.
Muchas gracias, Pedro, y muchas gracias también por la invitación. Muchas gracias por este tipo de eventos, por este tipo de diálogo que son tan necesarios, ¿no? Para poner en colectivo las cosas que están pasando en países como el mío. Primero quiero hacer una breve presentación. Yo represento a la ISP, aglutinamos a más de 30 millones de trabajadores públicos en 4 continentes. En Chile afiliamos a 9 organizaciones nacionales del sector público que representan más o menos 500.000 trabajadores del Estado, de la administración central, municipal, los sectores de control, recaudación, justicia, salud, educación, y también los trabajadores del agua, a pesar de que en Chile el agua es privada. Creo que la coyuntura política que enfrentamos tiene una gran relevancia, no solo para la vida política chilena, pues también creemos que se configura como una oportunidad histórica para que nosotras y nosotros, la gran mayoría de la clase trabajadora, se articule para poder incidir de manera decidida en los rumbos de la vida democrática de un país que, como dijo Pedro, ha estado subordinado por décadas a las políticas neoliberales que han precarizado a un pueblo que se levantó en octubre del 2019. Como organizaciones sindicales hemos dado una dura batalla contra estas políticas neoliberales que han impulsado la privatización de los bienes y servicios públicos en Chile. Consideramos que la intervención pública del Estado en la construcción, mantención y desarrollo de una red de servicios públicos de calidad es fundamental tanto para la vida de las personas como también para el adecuado desarrollo de nuestras economías. Creemos que esta concreción del anhelo de una vida digna, los servicios públicos juegan un papel fundamental. Creemos que cuando son estos servicios públicos de calidad permiten que nuestras comunidades sean más equitativas, sean sensibles a las desigualdades de género, sean más resilientes frente a situaciones de crisis, y lo vivimos con la reciente pandemia y lo seguimos viviendo aún, y también solidarias con quienes tienen más necesidades, como los niños, los jóvenes, las personas mayores, las diversidades de género, quienes viven con alguna enfermedad, discapacidad, etc. Hemos venido por muchos años también relevando nuestra propia narrativa respecto a que los servicios públicos de calidad son fundamentales para poder apoyar también el despliegue de nuestras economías, al sostener la inversión en infraestructura pública, asumir estos riesgos de largo plazo en investigación, innovación y desarrollo de nuevas tecnologías, educar y cuidar de la salud de quienes trabajamos y proveemos un entorno institucional jurídico estable. En definitiva, creemos que los servicios públicos son la puerta de entrada de las personas a sus derechos sociales. Como dijo Pedro, en Chile se impuso una de las experiencias más agudas de aplicación ortodoxa del modelo neoliberal, como lo dije en mis primeras palabras, a partir del año 73, con el golpe de Estado, que se impone a sangre y fuego. Se generan una serie de transformaciones económicas, políticas, sociales y culturales en Chile, transitando desde el modelo de industrialización progresiva sustitutivo de importaciones bajo la lógica del Estado responsable de desarrollo económico y de derechos sociales hacia un Estado subsidiario con alta injerencia del sector privado. En definitiva, una transformación cultural que instala la lógica del individualismo, la competencia, el consumismo, en oposición a una cultura de lo colectivo. Ello se expresó con mucha fuerza en una agenda privatizadora iniciada en dictadura desde el año 73 hasta el año 89, pero que también se extendió y consolidó durante el periodo democrático desde el año 90 en adelante. En tal sentido, asistimos a diversas oleadas de privatización, externalización de servicios públicos, tanto de empresas estatales como también de servicios públicos y bienes naturales en común. Nosotros como ISP en abril del año 2020 lanzamos un estudio que se llamó 30 años de política neoliberal en Chile, privatización de los servicios públicos, que puso de relieve tres fenómenos que grafican lo que hoy día viven los servicios públicos. Primero, la formación de verdaderos mercados en áreas de políticas públicas y servicios sociales, tales como el mercado de la educación, de las pensiones, de los servicios de salud, de la gestión y distribución del agua. Además, la cesión de espacios de gestión pública a actores empresariales, que ha posibilitado una brutal transferencia de recursos colectivos a agentes privados. Lo segundo, el estudio también concluye que el acceso a los servicios públicos está segmentado de acuerdo a la capacidad de pago que tienen las personas para poder acceder de ellos. Entonces, los que tienen plata se van a la salud privada y los que no a la salud pública. Y también el estudio relevó la precarización y desfinanciamiento de nuestros servicios públicos, en la misma medida que aumentan los beneficios para los actores empresariales incrustados en esta provisión de servicios sociales, disminuye entonces el retorno de la inversión. Y es así entonces como el estudio devela este verdadero mercado de los servicios públicos. Esto, y cómo los chilenos hemos vivido durante 30 años esta precarización, tuvo su culminación o su estallido, digamos, en octubre del 2019, en la revuelta, en la llamada revuelta social, que estalla de un proceso de movilizaciones iniciadas ya en gobiernos anteriores por distintas causas, donde la primera es sin duda la falta de acceso a la educación, el medio ambiente, las pensiones precarias totalmente privatizadas, la salud, el acceso al agua, etc. El 15 de noviembre del 2019 se firma un acuerdo de paz y se abre espacios a la participación en la construcción de una nueva constitución a través de un proceso constituyente que contó para su concreción con una convención constituyente paritaria y con escaños reservados para los pueblos originarios. Es en este marco en que la ISP define una agenda en estrecho vínculo, nuestras organizaciones más bien definen una agenda en estrecho vínculo con la hoja de ruta de la propia Internacional de Servicios Públicos en su último Congreso Mundial, donde se aprueba el Manifiesto Global por los Servicios Públicos, y por el... Ay, se me cayó esto. Un momento, que me caí. Ahí está. Perdón. Definimos entonces una agenda como organización en estrecho vínculo con la hoja de ruta de la ISP, donde pusimos de relieve el Manifiesto Global de los Servicios Públicos y también el esfuerzo decidido de los sindicatos del sector público en Chile para poder incidir en el proceso constituyente a través de un documento que nosotros denominamos Servicios Públicos de Calidad, Ideas para una Nueva Constitución, que lanzamos justamente el 23 de junio del año pasado, en el marco del Día Mundial de los Servicios Públicos, con la presencia, por supuesto, de algunos compañeros constituyentes. Diseñamos tres grandes ejes que observamos como condición necesaria para poder construir un Estado social, democrático y garante de derechos. El primero se refería a asegurar las condiciones institucionales que pudieran permitir construir servicios públicos universales y de calidad para una vida digna. El segundo buscaba proponer transformaciones constitucionales que permitieran avanzar en una justicia fiscal para una vida digna. Y el tercero tenía relación con diseñar una redacción constitucional que permitiera construir una resolución colectiva del trabajo de cuidados, enfrentar las brechas y desigualdades mediadas justamente por el género. Avanzar en una transformación del Estado en la perspectiva que acabo de señalar requería desde su diseño que los servicios públicos contemplaran inversiones permanentes pensando en el futuro de las comunidades. Y en ese sentido también requeríamos estar permanente, o sea, pensábamos que los servicios públicos necesitaban estar permanentemente financiados, disponibles desde una perspectiva universal para la ciudadanía y administrados también en forma participativa. En ese marco definimos como desafío, en alianza con la Iniciativa Global por los Derechos Económicos, Sociales y Culturales, hacer un cabildo ciudadano la segunda semana de diciembre, donde concurrieron muchas personas, más de 60 personas, entre representantes sindicales, trabajadores, usuarios de los servicios públicos, movimientos sociales, para poder construir una norma que permitiera impulsar en la discusión constitucional chilena de la nueva Carta Magna el tema de los servicios públicos. Y es así que presentamos la iniciativa popular, la 18.202, que se llamaba justamente Servicios Públicos de Calidad y Política Justa para la Garantía de Derechos Sociales. Estas iniciativas populares de norma entraban solo a discusión del nuevo texto constitucional vía firmas. Por lo tanto, de las más de 2.500 iniciativas populares de norma que se presentaron y se admitieron, solo 78 obtuvieron las firmas de ciudadanos para poder ingresar al debate de la Convención Constitucional y la de los servicios públicos obtuvo casi 17.000. Nuestra iniciativa de norma proponía, primero, terminar con el actual modelo de Estado subsidiario para consagrar un derecho social, un Estado social, democrático y de derechos. También proponía reducir la primacía del derecho a la propiedad privada que hoy sustenta la lógica subsidiaria en la Constitución de Pinochet, el poder eliminar la exigencia de los elevados quórum para aprobar la intervención pública necesaria para asegurar la provisión de servicios públicos de calidad, desplazando el peso que actualmente tienen los empresarios en estas actividades. Poder provisionar universal y públicamente los derechos sociales con perspectiva de género. Y cuando hablo de derechos sociales me refiero a la salud integral y oportuna, a la educación pública, gratuita y de calidad, a la vivienda digna, a las pensiones con un pilar solidario, al trabajo decente, a la recuperación del agua. Y además también proponíamos un sistema tributario progresivo, porque consideramos que efectivamente la política fiscal debe promover la igualdad sustantiva de todas las personas a través de un sistema financiero y tributario basado en los principios de la justicia, de la equidad, de la solidaridad y la progresividad con capacidad para poder reducir el ingreso y la riqueza. También proponíamos...
Tres minutos, por favor.
Perfecto. Estoy terminando. También proponíamos un reconocimiento y valoración del trabajo de cuidados. También proponíamos que el cuidado fuera un derecho humano. Proponíamos también condiciones de trabajo decente para quienes brindaran estos servicios públicos y también un reconocimiento a los y las trabajadores del sector público como sujetos de derecho, porque hoy día no tenemos como trabajadores públicos derecho a negociar colectivamente, derecho a sindicalizarnos, derecho a nada. Entonces también introdujimos esa lógica dentro de la propuesta de iniciativa popular. ¿Qué es lo que conseguimos hasta el día de hoy, en donde ya hay un texto armonizado y donde lo pretendemos votar el próximo 4 de septiembre? Logramos que se incluyera un artículo 28 donde habla expresamente de los servicios públicos y señala que es deber del Estado proveer de servicios públicos universales y de calidad a todas las personas que habiten en su territorio, los cuales contarán con un financiamiento suficiente. Eso hoy día lo trae el texto de la nueva Constitución. También dice que el Estado planificará, coordinará de manera interseccional la provisión, la prestación y la cobertura de estos servicios bajo los principios de generalidad, uniformidad, regularidad y pertinencia territorial. Y también logramos que en el artículo 1 de la nueva Constitución se estableciera que el Estado de Chile es un Estado social, democrático de derecho, y es deber del Estado garantizar las condiciones necesarias y proveer bienes y servicios para asegurar el igual goce de los derechos y la integración de las personas en la vida política, económica y social. Es decir, Pedro, de todo lo que nosotros presentamos se aprobaron estos dos articulados dentro de la Constitución, además de normas auxiliares que garantizan condiciones de acceso a los derechos, modernización del Estado, un monitoreo en la implementación de estos servicios públicos, avances en la ciencia, convenios entre entidades territoriales, cláusulas de mantención de organización centralizada. También se aprobaron normas respecto a la administración ecológicamente responsable, se aprobaron normas respecto al principio de la función pública, la igualdad en la prestación de los servicios, el principio de la participación, es decir, normas auxiliares e interpretativas que hablan del trabajo decente en el empleo público, de la prohibición de fines de lucro en instituciones de educación, principios de progresividad y no regresión de los derechos fundamentales, y lo que a nosotros también nos congratuló fue también la aprobación de una norma auxiliar que habla sobre el financiamiento de los derechos fundamentales a través de los servicios públicos. Creo que finalmente avanzar en un nuevo Chile justo y solidario requiere que los servicios públicos de calidad estén permanentemente financiados y disponibles desde una perspectiva universal para la ciudadanía, y a la vez que sean administrados en forma participativa y democrática, ética y transparente, y creemos que el nuevo texto de la nueva Constitución, que ya está armonizado y que hoy día está a disposición de la ciudadanía para ser votado el próximo 4 de septiembre, nos abre una tremenda oportunidad y posibilidades para que nuestro país se desarrolle, para que nuestro país sea mucho más democrático y para que sus trabajadores y trabajadoras puedan brindar mejores servicios de calidad a la ciudadanía. Muchas gracias, Pedro.
Muchas gracias a vos, Nairet. Muy importante esa intervención y con mucho detalle, mucha claridad. Así que muchas gracias por esa intervención. Bueno, ahora tenemos un video de Amaya Alves, de la Universidad de Concepción. Amaya es abogada, doctora en Derecho por la Universidad de York, en Canadá. Durante los últimos 23 años, ha sido académica de la Universidad de Concepción, impartiendo las cátedras de Historia Constitucional, Derecho Constitucional y Derechos Humanos. Es investigadora del Centro de Recursos Hídricos para Agricultura y la Minería, parte del Grupo Interdisciplinario de Investigación en Derechos Humanos y Democracia, y ha desarrollado diversos trabajos sobre derecho constitucional, derechos humanos, regulación del agua y pueblos originarios, tanto a nivel nacional como internacional. Hoy es constituyente por el Distrito 20, que agrupa a las comunas de Concepción, Talcahuano, San Pedro de la Paz, Coronel, Hualpén, Chihuayante, Tomé, Penco, Hualqui, Santa Juana y Florida. Perdón, son nombres no muy fáciles. Se presentó en la lista Apruebo Dignidad, representando a la Revolución Democrática e Independientes. Ahora comparto el video de doctora Amaya. Por favor.
Mi nombre es Amaya Alves Marín, soy profesora de Derecho de la Universidad de Concepción y también soy convencional constituyente en la convención que actualmente redacta la nueva Constitución. Estamos terminando nuestro trabajo, de hecho votamos las 3 últimas sesiones para luego ya proponer a Chile un nuevo texto constitucional. Me voy a referir justamente a la propuesta de texto constitucional en materia de aguas que hemos formulado durante el último año. Es importante porque esta Constitución contiene por primera vez en la historia de Chile un capítulo completo que se denomina Naturaleza y Medio Ambiente. Ese capítulo completo denominado Naturaleza y Medio Ambiente contiene normas sobre bienes comunes naturales, un estatuto de las aguas, un estatuto de los minerales y una defensoría de la naturaleza. Contarles que bajo la Constitución de 1980, la Constitución que actualmente tenemos vigente, las aguas fueron reconocidas como un bien natural de uso público, pero de manera un tanto contradictoria se permitió que se estableciera un derecho de propiedad sobre las aguas. Entonces, a pesar de que se reconocía que la titularidad del agua era para la nación toda, y se reconocía esta condición de bien esencial para la vida colectivo, aún así, en la Constitución de 1980, la que queremos reemplazar, se reconoce que existe propiedad sobre el agua. Y el efecto de esa ficción jurídica fue crear un modelo que estableció una propiedad, y eso ha sido, en el fondo, creó un mercado, creó una especulación, creó también, dada que el agua es cada vez más escasa, es un bien que ha ido aumentando su valor. Entonces el Estado hacía y hace esta primera entrega gratuita, pero luego en el camino, después de la primera entrega, estos derechos de aprovechamiento de agua son transferidos en mercados de agua a valores a veces muy altos, y mientras más escaso, más alto. Este modelo se quiere dejar atrás, y por eso la nueva constitución, la constitución que vamos a votar el 4 de septiembre del 2022 en un plebiscito obligatorio en Chile, propone que el agua sea un bien natural común. Un bien natural común lo establece específicamente el artículo 134, que se propone cuando señala que los bienes naturales comunes son elementos o componentes de la naturaleza sobre el cual el Estado tiene un deber especial de custodia, con el fin de asegurar su preservación, su conservación y el interés de las generaciones presentes y futuras. Es relevante esto porque uno de los elementos que se considera bien natural común señala luego ese mismo artículo, el 134, que son las aguas, los glaciares, los humedales, entre otra numeración. Entonces el agua en sus distintos estados es un bien natural común. También se reconoce que los pueblos originarios tienen usos tradicionales, y específicamente en el catálogo de derechos fundamentales se reconoce en el artículo 57 que existe un derecho humano al agua y al saneamiento como una jerarquía superior. Si hubiese una jerarquización, quedaría en el primer lugar lo que dispone el artículo 57, cuando señala que toda persona tiene derecho humano al agua y al saneamiento suficiente, saludable, aceptable, asequible y accesible. Esos son el estándar internacional de derechos humanos. Y luego indica